Hi everyone, my name's Kristen and I'm a clinical nurse specialist, and today we're going to be talking a little bit about graft versus host in the liver transplant patients. So the title is Graft versus Host Liver Transplant Edition, and this is an informational session designed based on some feedback we got from the staff, so hopefully you're going to enjoy it and learn something. All right, so before we begin, going to start off some goals. So we're going to go over what is graft versus host, kind of the history behind where it came from, what are some of the risk factors, the things that we know about, the things that kind of we suspect as risk factors, as well as what is the typical presentation in these patients, as well as diagnosis factors. For treatments, we're going to talk a little bit about the first line of defense, and then we're going to go through into some of the novel therapies, go on to prognosis, and then finally close off with some patient case studies that we've had here. The other thing I want to mention before I begin is, while I don't have any bias to disclose or conflict of interest to disclose, I do want to mention a quick shout out to another clinical nurse specialist colleague, Misty, who is a clinical nurse specialist for our bone marrow transplant patients, and she has done a lot of speaking nationally on our patients with graft versus host disease and our bone marrow and stem cell patient population. So she was kind enough to help me with this presentation, so I just wanted to give her a little shout out. Okay, so graft versus host. It's a well-known complication of the stem cell world and stem cell transplantation, and it's really described as an immunological response. It's known as a severe but rare complication when it comes to our transplant patients, our solid organ transplant patients, but most of the literature and most of the case studies you see with large amounts of patients in them, or at least a larger amount of patients in them, come from our bone marrow friends. So what we're finding is a lot of the things that the folks in our stem cell patient population have discovered or used to try to treat their patients, they're trying to translate now into our solid organ transplant patients, knowing that the mechanisms of action act a little bit differently in these patients, but it's definitely very similar. It is a very life-threatening complication. Several studies reported of these patients, our graft versus host, happening in our liver patients. It's scarce in the lung, pancreas, as well as kidney. But it was first described in 1988, and it's thought to be that this has actually been happening for a while in these types of patients. However, unfortunately, you can't usually figure it out until it's too late, or your patient succumbs to another illness, and this may not have ever been discovered. Overall mortality rate, when you read the literature, is roughly 87%, and it occurs in 0.1 to 2% of the liver transplant patients. It's defined as a presence of donor lymphocytes in the graft, and it's commonly divided into two phases in the stem cell patients. The acute phase, which happens within the first 100 days of allograft transplant, and then the chronic phase, which happens 100 days following an acute episode. It is unique to, one thing that is really unique to the solid organ transplant patient is that there can be bone marrow involvement in graft versus host in these types of patients. And the thing that I think is interesting in the patients that have bone marrow transplants that get graft versus host is that they can have liver involvement. So it's kind of one of those swap-aroos that's happening there in that. So again, there's more known about graft versus host in stem cells. And so what they talk about a lot in those patients is that it's known that there's an HLA disparity. So when you're talking about a match, there's some kind of a marker that there's a disparity in. They've seen that it happens more in patients that are older than patients that are younger. And the greatest chance of this occurring is if there's a sex mismatch between a female donor to a male recipient. In our liver transplant patients, what we've discovered over our own data, as well as some of the research that is out there, is that some of the risk factors that have been identified are patients that are greater than 65 years of age at the time of transplant, patients that receive a transplant from a younger donor or a donor that has a greater than 40-year age gap, alcohol, liver disease, meaning that the patient had a diagnosis of that pre-transplant. It's also hypothesized that there can be a higher risk for patients that have hepatocellular carcinoma, as well as specific recipient immunological mismatch. This to me is kind of one of those statements you say, kind of like the word, which I don't really like this word, but the word idiopathic, where we're not really quite sure, but we believe that there's something to do with some kind of a mismatch that we just haven't discovered yet. The common organs that are affected in the acute graft versus host as well, when you look at the big picture from our bone marrow patient population, there is skin, gut, and liver involvement. Again, we don't really see the liver involvement as much in our patients, and we see bone marrow involvement in our solid organ transplant patients. It does traditionally present, though, as a maculopapular rash. And if you know a lot about rashes, or even if you know a little bit about rashes, when you're in school to getting your advanced practice degree, or really when you're talking about any kind of dermatological kind of course of action, the first thing you talk about when you talk about rashes is most things are dermatitis until proven otherwise. This rash is not very distinct. It is very benign looking, and it is very much an imposter of several other rashes. There's lots of pictures in this presentation, so hopefully you'll be able to take away that it's not just the patient has a rash and they automatically have graft versus host. There is a kind of degradation or breakdown of the mucosa of the GI tract, and this really can happen anywhere in the GI tract. But a lot of the times the patients present with diarrhea, abdominal pain, nausea, and vomiting. And in the bone marrow transplant patients, there is a degradation of the biliary tree, which causes a rise in liver enzymes, jaundice, and hepatomegaly. The symptoms are usually just mistaken for other things or other disease processes. Most patients are really admitted, not usually for a rash, but usually admitted for fever or low white blood cell count, as well as nausea, vomiting, diarrhea, which is normally what we see in our solid organ transplant patients. This can appear anywhere from weeks 1 to week 12, depending on which literature you see in these solid organ transplant patients. There are a lot of differing opinions when it comes to this, and that is why the range is so large. But you have to remember as well, with a patient population that's getting this, where the incidence is so low, despite it being so fatal, it makes your N very small. So it does make it very, very hard to come up with a tighter range than that. So the first presentation we're going to talk about is skin. And here are some pictures of this maculopapular rash. And the reason why it's hard to identify is these patients are usually started post-transplant on several medications that they've never been on before. And a lot of the things that you see here are very, very similar to a drug eruption rash. And so it is very difficult to rule that out based on the fact that the patient is going to have a lot of the same symptoms and it's going to have a lot of the same presentation as that kind of a rash. But it does typically affect the chest, trunk, and it can also spread to the neck and arms. You can see it on the soles of people's feet, which is something that's a little bit different. You don't usually see drug rashes there. But again, it can be commonly mistaken for some kind of an allergic reaction. It is usually coupled, though, in our graft versus host patients with a drop in their platelets or a drop in their white blood cell count, and it is usually very rapid, and it can get progressively worse. So the pictures here from the top, the picture is how it looks on somebody's hand, up close on a forearm, and then the bottom picture is a patient with darker pigmented skin. And as you can see there, it is very difficult to identify because this patient was a liver transplant patient, and they already had some itching at baseline and had some scarred over areas there. So if you have other things that are going on with your skin, which we know happens in a lot of our liver transplant patients, it does make it very difficult to diagnose. In advanced cases, rashes may progress to a generalized ulcerations or those bullous lesions, or you might even see kind of sloughing off of the skin. Hair follicles can also be injured or destroyed. Really our goal when it comes to caring for patients that do have this kind of a rash is to maintain the skin integrity, because we're really trying to keep these patients' skin intact as much as possible, because we know that the skin is the largest organ in the body, and it is one of our largest protecting points when it comes to our immune system. So we really need to try to keep the skin clean and hydrated. These patients may or may not be able to tolerate CHG, so it is important that we try to keep them infection-free as possible, but also weigh the risk-benefit there. There are some antipyretic options. We do like to try ointments in a lot of these patients. They can be less drying, or we can try some steroid creams such as triamcinolone, except you can't put steroid creams on somebody's face. So we do usually try to use those things to try to help with the itching. One other final thing to say about that skin is just that skin is also diagnosed or also kind of staged like burns, but we usually don't end up staging our solid organ transplant patients that way. We usually do stage them based on their GI stuff. So let's talk a little bit about that. So if it comes to graft versus host with the GI presentation, they're going to be usually presenting with diarrhea. They could have some abdominal pain and cramping. Some of them have an ileus or presentation like an ileus. They do have nausea and vomiting. It is usually unresponsive to antiemetics. Weight loss and dehydration, which are kind of just consequences of that nausea and vomiting and unable to keep things down. So it is important that we get a comprehensive assessment with a detailed history. Also involving our GI people and our GI physicians to probably scope this patient to get a biopsy to find out the true source of this, because we know in the transplant patients that, again, we have a lot of new medications and a lot of things that can be going awry, so we need to make sure we're ruling those things out. So diarrhea and emesis, though, when it comes to your assessment, it's really important to think about how much are they having. Volume is really the key here. We do need to mark how much is coming out, what is the color, the consistency, and the frequency. It is important to obtain a stool culture, because a lot of the treatments that we talk about a little bit later on for graft versus host, we want to make sure that we are not doing anything to make something worse, and we don't want to create a super infection, and giving steroids or a large amount of steroids at least to a patient that has an infection can often be fatal. So we need to make sure that we've ruled those things out. Your skin also kind of couples in with this, because you do have skin in those areas, and if you are having a lot of incontinence or even lots of diarrhea, you are going to be at risk for some skin breakdown. So it is important to do good peri-care and to make sure that you're applying a barrier cream to these patients. We do use some medications in these patients called beclomethasone. It's a topical therapy, and it's a minimal absorption, allows for the excretion of local inflammatory effects while limiting the systematic effects. It's essentially a steroid that kind of helps with the inner lining there of your gut or your GI tract. So the pictures that are on the left-hand side closest to the text are showing you the patient that has some ulcerations from graft versus host. It's, again, very distinct ulcerations, but it's hard for us to determine based on all those risk factors what else is going in there. So it's important for them to get a biopsy. And then the microscope slides there are just interesting, because you can see the cell death that is happening here. You can see the destruction on the surface of the lining of the colon, as well as the cells that are dying and being invaded by those donor cells on the bottom slide. Okay, so I mentioned staging. So staging, again, in the GI is what we commonly see in these solid organ transplant patients, and it is staged based on, really you see here, it is staged based on the amount of stool. So that is, again, why it is very important that we are marking it down how much stool they are having. Upper GI, yes, it is important to mark down their vomiting, but most of these patients, the main symptom is diarrhea, so it is important that we are marking that down. And when we talk about treatments, there is differences when it comes to the stages of it, similar to cancer. But more or less, it's not the type of treatment, it's just more the response to treatment. And if somebody is having that large amount of stool, again, we mentioned the skin, but the other thing I forgot to mention or failed to mention there was just we need to be careful about their electrolytes as well as nutritional support. They might need to have a special diet. Think of some of our patients that have like celiac disease, or patients that are on these low residue diets. For a colitis episode, we probably need to be thinking to giving these patients something to help calm those things down, like avoiding milk, avoiding caffeine, low fiber, low fat, some things that can try to help give a little bit of gut rest with a little bit of nutritional value as well. So bone marrow. So bone marrow failure commonly is what leads to the unfortunate demise of these patients, because it leads to sepsis and death in the solid organ transplant patients with graft versus host. There's a low likelihood, if it gets to this point, that blood count recovery will occur. There's a marrow CD3 chimerisms are what we use to help diagnose it. It is helpful to get serial bone marrow biopsies. However, you kind of have to weigh the risk benefit as well as the pain there. Bone marrow biopsies, well, they're a great tool. They are not pleasant for the patient. So we definitely need to weigh the benefits here to see if that's going to change course of outcome. HLH, or hematopoietic lymphocytosis identification, is something that we're really pouring a lot of research into, or a lot of funding into. It's related to a cytokine, similar to a cytokine storm, where there's an uncontrolled overactivation of the immune system that can cause some damage to the cells. They're looking for some targeted therapy to try to calm that portion down. So that's really going along with the dysfunction that we're seeing in the bone marrow of these patients. All right, so let's talk a little bit about diagnosis. Unfortunately, most of these patients don't present with a big flashing sign that says I have graft versus host. So delays in diagnosis do occur, but it also can influence the prognosis of the disease. Skin biopsy is important to obtain from the rash. It's really kind of the true marker when it comes to it. It isn't definitive, though. It's often one of the things where it will come back and it will say this is the likely graft versus host, versus drug eruption. So you kind of still need to go down that road, but it is important to obtain that, because if it does not show something like that, maybe it's going to show that the patient has a fungal rash or something like else that we can treat. So it is important to get, even though it might not be the most discerning thing for diagnosis. There's something called a FISH study that I have a slide on next that we can do on kind of different different systems. But you can get it on the skin. You can use it for blood. You can use it for bone marrow. That can check your chimerisms, but it's going to show you. It's directed at the Y chromosomes in the sex mismatched patients to kind of see which is taking over there. Chimerism presence of the donor lymphocytes in the recipient's peripheral blood, skin, or bone marrow are also going to be an identifier of the diagnosis here. It can show lymphocytic infiltration on the molecular level. And then also, again, we need to consider that bone marrow aspirate as something to help make a definitive diagnosis. This picture here is just really showing you what a FISH study is. It's mentioned a lot in patients that are getting this diagnosis or getting worked up for it. And really, we're taking this marker, this fluorescent marker, and we're trying to mark portions of the DNA to see which portions of it are kind of hanging out there. They use it in cancer diagnosis. That's really what you see it done in a lot, but it is being used in graft versus host to try to see which cells are there. They can also mark the sex chromosomes to see pretty easily if the donor cells are taking over, and can identify the proportion of donor cells in the sample. You can see this with skin, a bone marrow biopsy, as well as peripheral blood. They usually are able to draw this and send this out. It is not a test that you usually wait on the diagnosis. If you're sending this out, you probably have other confirmatory diagnoses or tests that are pending at the same time. So let's talk a little bit about nursing and what do we do in this situation. So our goal is really to support symptom management, to control the diarrhea as best we can and support the patient. Getting accurate I's and O's, as mentioned, when it comes to diagnosis and staging of graft versus host, as well as keeping an eye on how much fluid is this patient down, how much weight is they down, and how can we best support them. It's very important on these patients specifically. Nutritional support, finding what the patient can eat, able to eat, tolerate to eat, and advocating for that is really important. Getting them IV fluid if necessary, making sure they have the appropriate access. Oftentimes, by air, ETA, 8 minutes. Oftentimes in these patients, you're going to see that they might be running through veins, meaning that they're getting a lot of electrolyte replacements, or they're needing fluid replacements, maybe they're needing blood replacements. And so you might be burning through a lot of veins, and you might be finding yourself where this patient needs more permanent access. A lot of these patients in the James are getting PICC lines. So if your patient is eligible, that's really a good choice for them for a central line. It is something you're able to leave in for a little bit longer than a temporary CVC, and you're also able to pull it pretty easily if they were to happen to get an infection. You are probably going to be preparing them for a colonoscopy, so that's never a fun experience when you're already experiencing GI upset. So supporting them the best you can with that, advocating for them, making sure they have good skin care, perianal care. Medication administration, we might be giving them some other supportive medications. I mentioned beclomethasone again here, as well as our wound care. It is important that we are taking care if these patients have any other areas that are putting them at high risk for infection, because they are going to not have the proper immune system, even more so than just a normal solid organ transplant patient, putting them at risk for all those opportunistic diseases. So primary treatments are usually to decrease the immune suppression. We need to try to give that immune system kind of a fighting chance to reject the donor lymphocyte that's mediating graft versus host. This, of course, does usually or could lead to some kind of a rejection. So we really need to make sure that we're mentally preparing the patient for that, and they're talking to the patient a little bit about what that's going to look like. Other conventional treatments are usually steroids. Steroids like methylprednisone are very commonly used in these patients. It's usually a dose of 2 milligrams per kilogram per day, and they'll often start this while they are waiting on some of the other testing to come back. It is important that your infectious testing is kind of already been done or has already come to a conclusion, because we don't really, again, want to be starting steroids on a patient that has a massive infection unless it's truly indicated. But outside of that, steroids are okay to start in these patients while we're waiting on their diagnoses. I will say though, when I was able to look up how well people respond to treatment, it really does depend on, most of the literature, at least that's out there, does depend on what stage of graft versus host they're at. So patients, for example, that are at a stage 2 or graded 2 of graft versus host have a 63 to 95% response rate. But if they get down to grade 3 or grade 4, it drops to grade 3 is 17 to 39%, and then grade 4 is all the way down to 4 to 6%. And unfortunately, some of these patients are refractory to steroid treatment, and so we need to figure that out and then decide on the next novel treatment. There can also be a reduction in mycophenolate if leukopenia occurs. We have tried other immune suppression medications to help deplete donor T cells or block T cell activations. Again, patients are at most risk for life-threatening events related to profound immune suppression. So it's really important that we're keeping a very close eye on their white blood cell counts during this vulnerable time. One of the novel therapies that we've seen in some of these patients recently is ECP therapy, or extracorporeal photopheresis, and this is done in our apheresis suite. They can do it outpatient, but most of them are done at these pheresis locations, and your blood is getting exposed to a certain chemical or a certain kind of isotope, and it's followed then after that by a UV irradiation. And the thought is that the blood is hopefully getting those cells removed. Then the blood is then returned to the patient. So psoralen binds the DNA and promotes the cross-linking with the UVA, which causes the cell death to occur. So they should be having cell death of hopefully these donor cells in the next 2 to 7 days following the treatment. So it is a novel treatment. They do use this a lot in the stem cell patients or bone marrow transplant patients that get graft versus host, but this is something we're starting to see in some of our patients. Usually it's done a couple times a week, and they do need the same kind of access that they would for apheresis. Other novel therapies that have been out recently are JAK inhibitors. I have the first one listed there. It's established really in managing graft versus host. Again, most of these medications have started out in the bone marrow transplant world and have kind of started to cross over. But this is often used as a second-line treatment when refractory to steroids. It targets the JAK1 and JAK2 pathways, and it's crucial for signaling the inflammatory cytokines. So that is what is happening. Those JAK1 and JAK2 pathways signal your inflammatory cytokines, and this is really shutting that pathway down. There are several other medications that are currently under investigation that we don't use quite yet, but might be seeing those in the future that work very similarly. The other thing we might be seeing is a monoclonal antibody, tumor necrosis factor alpha, which is etanercept. It's the initial or first-line therapy for steroid refractory graft versus host. We have considered ATG or basiliximab kind of for the same reasons in these patients, not seen as much though, now that we're starting to see some more medications specific to graft versus host kind of be funneled through the pipeline. It is important to consider antimicrobial therapy, antifungal therapy, all the things for these patients, because opportunistic infection is often what leads to patient demise. Can't emphasize that enough. Anything you can do to prevent these patients from getting an infection, be it getting a line removed, be it keeping their wounds clean, be it keeping them from getting skin flares, anything you can do to prevent them from getting an infection needs to be done, because that is truly what kills these patients. That is what causes their demise. It is very similar to when you think about patients that die of AIDS. They don't die from AIDS, they die from an AIDS-related disease. I know that's an older example, but that's the first thing that comes to my mind. It's these opportunistic infections that are usually what happen to these patients. So some of the common things that we want to prevent them from getting are PJP pneumonia. Antifungal prophylaxis can be done for prevention of aspergillus, CMV prophylaxis, or broad-spectrum antibiotics to hopefully cover the gram-negative bacteria that can be out there, as well as anaerobic bacteria such as VRE. It is really important to consider supportive therapies. As we saw in the one statistic, I said that 87% of the patients, based on what we can find in the literature, will unfortunately succumb to ultimately something from this disease process. So we need to make sure that we're consulting palliative. I know I have that on here last, but it definitely should be first. There's a high mortality rate and a high rate of graft loss, so it is really important that we get them involved when we first started talking about this. Palliative does not mean giving up. Palliative is supportive. Palliative is supposed to help any kind of transition or any kind of difficult portions of your healthcare journey. So it's really important if they can be supporting this patient and their family through this process that we allow them that. Blood glucose monitoring is also really important. We do a lot of steroids in these patients, so we want to make sure that we are not causing them to have diabetes or steroid-induced diabetes. Steroid-induced diabetes can also lead to your patient getting lots of infections, and we don't need to give the infections any more good things to help them grow. Steroids plus diabetes in the set of somebody that's at high risk for an infection already will make for a super infection, and we don't want that. You're probably going to see a lot of these patients getting serial viral levels of many things, including EBV. Those are usually send-out labs, but you will see that quite frequently. And then we also need to consider other supportive therapies. I have listed on here PPIs and H2 inhibitors, but anything we can do to help their symptoms subside that is not going to be counterproductive for the rest of their treatments would be helpful. So I put this slide in here because my first thought when I was putting all these things together and when I'm really thinking about the picture of graft versus host is how do you not think that everything is graft versus host? Because I kind of feel like this. You're trying to put this puzzle together and there's so many pieces and you don't even know where to start. And you're just thinking, well, everything, I should be thinking this all the time. But really we shouldn't be, right? Because if you're thinking about the worst of the worst all the time and you're trying to find that zebra diagnosis, you're going to miss the most common things, and that can be detrimental to your patient as well. It's really important that what we're trying to do is we are kind of simultaneously ruling out the things that could be going on, along with keeping in the back of our minds that if we can't figure these things out quickly, we probably need to start going after some of these other testing. We also don't want to give patients millions and millions of dollars of medical bills for something that we might be able to solve with just an x-ray or a simple blood test. So we really need to be putting on our critical thinking and keeping this in the back of our mind and knowing that this is possible, but knowing that the incidence of it is not very high, despite how it feels with the loss of the patient. So I put together this kind of decision tree based on the transplant clinical guidelines that we have for patients with graft versus host. So if you have a patient that has this clinical presentation of maculopapular rash, and they could have any of these kinds of things, maculopapular rash, they come in with some pancytopenia, maybe instead of that they have diarrhea, vomiting, plus or minus a fever with and maybe an infection concern, or maybe even they're septic. You kind of need to do a little bit of both sides of this. From the infectious side, we probably in most situations are going to be doing pan culturing them, including fungal cultures. We do live in a moist environment and we need to make sure that we're not missing anything like that. Chest x-ray, CT, MRI, whatever is appropriate for your patient depending on the symptoms. We also need to probably be testing their stool, especially if they're doing or having diarrhea. Need to make sure that they don't have C. diff. C. diff is common in transplant patients, unfortunately, because of the amount of antibiotics that they are on. So anything we can do to rule that out would be helpful, as well as checking their CMV. CMV can rear its head and be a cause of diarrhea, especially, and it can also cause some of these other symptoms. So we need to make sure that we start all those things. If our patient has a rash, we definitely want to get dermatology involved. After maybe even if we try maybe a topical steroid, we probably should ask dermatology, what are they thinking? If they have a rash in the setting of a couple of these other symptoms, it's definitely worth a consideration. If they are having diarrhea, it is worth probably doing a colonoscopy or a flex sig just to see if we can figure out what is causing this diarrhea. Is it simply that they are over immune suppressed and that's what's causing this, or do they have ulcers, or do they have some things that we need to biopsy to kind of rule this out? And then the bone marrow biopsy, maybe a FISH analysis if the transplants from the opposite sex donor would be pertinent information. For the diagnosis of graft versus host, our confirmatory tests that we have here are chimerisms post-engraftment, your CD3, your donor lymphocyte, macrochimerism greater than 1% in the peripheral blood, skin, GI tract, bone marrow, or buccal mucosa. All those are listed, knowing that this can be presented at any of those states there. And when we start treatment, we want to start treatment if biopsies are consistent with graft versus host. Again, a lot of these biopsies are going to say graft versus host versus, and which is kind of how you list out a differential diagnosis. So we do want to start treatment if our biopsies are consistent with it. We don't need to wait necessarily for these confirmatory tests on the left. If we have biopsies and we have the other signs and symptoms, we can go ahead and start those steroids. Okay, so what is happening here at Ohio State? What are our numbers here at Ohio State? What does it look like? How does that relate to what we're talking about here? So the first diagnosis that we can find of graft versus host happened in 2015, and our most recent diagnosis I have in this PowerPoint. This PowerPoint was prepared a few weeks ago, and the most recent was March. We've actually had one since then, and we do have a patient that's currently being worked up. So keep in mind this PowerPoint is only as good as the day that I put it together. At that time, we had 12 patients total. 11 were liver transplants, and we did have one kidney pancreas transplant thought to be from the pancreas, but it's debatable. So the numbers do include those two that were debatable, meaning that there was some back and forth between some of the providers as well as some of the things. Again, because a patient that gets better and is able to survive this with just some steroids, we do always have to wonder, was that truly what it was? Because it does say in those biopsies a lot of the time, like I said, graft versus host versus something else. So it can be debatable. So we had a total of 5 females and 7 males at the time of this that had been diagnosed with graft versus host. We had a 75% mortality rate, so better than what we're finding in the literature. And for perspective, we really do need to keep in mind how many transplants we do. I did want to put the numbers in here, but again, I was like, well, this is only going to be as accurate as when I put it in here. But think about the fact that we did close to 180 liver transplants last year. So it's quite a few liver transplants, and that's not a large number of an N here. So it is difficult to make trends and do trend line analysis here. So I do want to go through some case reviews just to talk a little bit about what does this look like here at Ohio State, or how are we seeing this? So the first case is a 68-year-old female. She had a history of coronary artery disease and an MI in 2016, history of hypertension, hyperlipidemia, hip surgery. She did have a liver transplant because she had liver failure related to alcohol abuse. Her liver transplant was in April of 2019. Her MELD was 16 at the time of transplant. She received her liver from an 18-year-old female donor. Both the donor and the recipient were both positive for EBV at time of transplant, so there was not a mismatch. Her initial length of stay was 12 days, and it was complicated by bradycardia, and she also, unfortunately, drew the short straw and developed varicella zoster. So she got shingles, and there was a biopsy done of that when that rash kind of erupted, and the biopsy proved that it was a herpes infection. She was readmitted twice post-transplant. The first time was for abdominal pain and diarrhea. We did check her CMV. Her CMV PCR was negative. Her stool was negative for C. diff. She did have a large amount of ascites. So we did go ahead and do a drain or a tap on her, and she felt much better afterwards, and her GI symptoms all resolved. We did have some concerns that were noted in her chart by multiple providers, nurses, provider, everybody, regarding narcotic-seeking behavior. She had a history of some drug abuse post hip surgery. She didn't feel like she was being medicated well enough, and so she did have that, and so that was mentioned in her chart a couple of times. So I don't know how, don't know necessarily that it played into the diagnosis there, but I think it's interesting, just given her whole picture, kind of tells you that there was a lot of things happening there. Then the next admission was abdominal pain again with vomiting. And it was a week later, and now unfortunately she had a low-grade fever of 100.4. They did some cultures on admission with no growth. 2 days into admission, kind of when they were still working her up for everything, she was found unresponsive. Code blue was called, and we were able to achieve ROS after 3 rounds of ACLS. She did end up in the ICU, and in the ICU she decided to go into AFib with RVR while she was on pressor support, which required an electrocardioversion to break that. She continued to have significant amounts of diarrhea, and unfortunately now was leukopenic. So this was, again, a few days, less than a week into her stay, and all those things. I mean, that sounds like a whole gamut of problems that happen in less than a week's stay. But now, unfortunately, this is where we start to see, now that she had this new diarrhea, or newer return, I guess you could say, of diarrhea, and she's now leukopenic. This is when graft versus host is actually mentioned in her chart as being a potential or a possibility. So we decided to do some chimerisms, and we planned to do a flex sig when she was clinically stable. None of the anesthesia or providers were very excited about doing a flex sig on her. because she was had gotten out of her crazy cardiac rhythm and was back on the floor, and they were thinking, I don't want to do this right now because of what her heart being that way. Unfortunately, she got a little bit unstable and had to go back to the ICU because she was had some altered mental status and became unable to protect her airway. When she was in the ICU, they were able to do her flex sig, and it did show an inflammation in her right colon and ileum. And during that flex sig, we did biopsy her, and the biopsies showed the following. Her colon showed markedly prominent crypt apoptosis, so cell death, significant crypt loss, and reactive epithelial changes. And her small intestine showed complete loss of epithelium and crypt. So she had lots and lots and lots and lots of cell death and lots of issues in her GI tract. That sloughing off was definitely occurring. Both of those results are suggestive of severe graft versus host. So we're thinking at least a stage 3, if not stage 4 graft versus host. So she was started immediately on Neupogen and trying to get together the rest of her plan. At that time, then she became a little bit more stable, and her stool changed to maroon, and she was noted to be having anasarca because they were doing lots of fluid replacements on her. So I included this slide not because this is her actual slide, but I wanted to show you some just microscopic things, like just because that is a big and lot of words that are listed in her diagnosis or in her biopsies. So these pictures here are showing you what does the normal mucosa look like. So the small intestinal mucosa here is on the left-hand side, and you can see those villi, the goblet cells, all the things you remember from nursing school. And on the right side, you're seeing the colon mucosa, and you can see the goblet cells that are lined along in there and the lymphoid tissue that happens. The next slide, or next page here, is showing you what graft versus host. So I included on the left side and is showing you your intestinal cells, and the right side is showing the colon cells, similar to the other setup we had on the last page. But we can really just focus on the left-hand side of the page because those are more, the slide examples I was able to find were stages 3 and 4, and knowing that's what she had, you can tell that those slides are a mess. The cells are not organized. There's lots of scattering happening. There's a takeover of lymphocytes that are occurring from the donor cell. You can just tell that it's organized. It's not even organized chaos. It's just chaos. So there's no way that is protecting you from anything. So unfortunately, that was what we were dealing with in her situation. Her pancytopenia was unresponsive to Neupogen, as I mentioned before, unfortunately, but that's not surprising. So we decided to, in her situation, to hold all of her immune suppression. We did consider a bone marrow biopsy, and we involved our bone marrow transplant or our bone marrow colleagues, stem cell colleagues, to ask them their opinion, because that's usually who helps in these situations. And they said that they consider aggressive treatment if no marrow involvement. Otherwise, they said that they would just recommend palliative care at this time. While we were trying to decide very rapidly, she became extremely unstable again. She was placed on several pressors, including an amnio drip, and she had increasing cardiac complications with lengthening pauses. So that same day, they consulted a palliative medicine. Now, do I think we could have consulted them earlier? Absolutely, probably 8 days before when we had started talking about graft versus host. But this is one of those hindsight's 2020. So when they started talking about this, they likely should have gotten them involved, but they did involve them. Palliative did speak to them at length, and the family decided to make her a DNR-CC on the 12th, and she was palliatively extubated and passed the same day. All right, so our next patient is a 73-year-old male. He had a history of a second-degree block. He also was MASH cirrhosis, esophageal varices, hepatic encephalopathy. He had the spontaneous bacterial peritonitis, and he had a liver transplant in October of 2025. His MELD at the time of transplant was 18. He received a liver from a 53-year-old male. So you'll see here that that is a closer of a match when it comes to age. So that's good, right? That can cross that part off of our list. And the recipient and the donor were both positive for ABV, but only the donor was positive for CMV. So we already knew going into this that the recipient was going to need to complete or do some prophylaxis for CMV to make sure that there wasn't that transfer there. The initial length of stay was 11 days. It was complicated by AKI and hyperglycemia. He was on Valsite for 3 months related to that CMV mismatch. Now, he was also admitted twice post-transplant. The first time was AKA with worsening hyperkalemia. He had extremely poor access the entire time, and labs were constantly an issue with him as outpatient. It was unclear if he missed some of them or if some of them were hemolyzed or whatnot, but it was always a challenge. He had a lot of complaints of nausea, vomiting, and diarrhea, and he continued to have those complaints with the stool study being negative. He did kind of have a little bit of a relief on his symptoms and was able to be discharged. His second readmission was for leukopenia and diarrhea. He also presented with a diffuse itching rash, and several days later, the patient was transferred to the ICU as it seemed like a sepsis presentation was likely. So while in the ICU, he was taken to CT scan, and the CT scan showed wall thickening of the small bowel and colon, so maybe some kind of an infection process happening there. And he had a TTE that showed a reduced EF and elevated BNP. So cardiology actually got on board with this case and started him on some dobutamine and pressors, and then we were able to get him weaned off. He did get pan-cultured, and he had a low level of EBV, but they were otherwise negative. And we did transition him from these large antibiotic broad spectrums down to like Levaquin or levofloxacin per infectious disease because they were involved. So his rash, they decided, we probably need to look further into this, and they did a skin biopsy. And his skin biopsy showed interface dermatitis, presence of follicular involvement, favors graft versus host, although drug eruption cannot be ruled out. So this is a picture showing you of kind of what those things look like. And then bone marrow biopsy, remarkably hypocellular, less than 10% bone marrow with essentially absent hematopoiesis. Chimerisms and FISH were performed. So hematology was consulted. He failed the medication to help with his white blood cells, and his immune suppression was ultimately held. He was started on high-dose steroids and Gvhd, which is one of those JAK inhibitors, and he was also placed on antifungal medication for prophylaxis. He was still, unfortunately, having symptoms, and we saw no relief, so he was started on alpha-1 antitrypsin, and that also, unfortunately, had no relief. He developed respiratory insufficiency, and his antibiotics were widened. He had a CT of his chest that showed a sub-centimeter ground glass nodules within the bilateral upper lobes and increased right and left pleural effusions. His blood cultures now were positive for gram-negative and gram-positive and bacteria. And so at that time, his family decided to change his code status, and we decided to withdraw support. So those are really sad. So obviously the patients that we just reviewed, neither of them made it. And so I think it's important to mention and to put a few things in here to kind of close this on more of a positive note, knowing that these patients, unfortunately, are not ones that are likely going to make it in a lot of these situations. So I thought that these were all very appropriate. We all care. We're nurses. You didn't get into the field because you don't care. And it'd be unrealistic for us to think that losing a patient, especially patients like this that you've cared for usually over months of a time, wouldn't be normal to not feel that way or to feel something about it. So compassion fatigue is not just a buzzword, it's a real thing. It's described as emotional fatigue stemming from encounters with compassion and stress. It can occur spontaneously. It can make you feel hopeless, alone, secluded, helpless, and nurses are at high risk for suffering from this because of the field we work in. And when you do suffer from this, it can cause you to be apathetic or to even have a little bit of compassionless care. Adverse events can also occur related to this, be it from the staff or to the patient. Moral distress is a little bit different. It does correlate with burnout, but it's defined as psychological disequilibrium that occurs when a provider can make a moral judgment about the correct choice, but you're not able to provide it. So it's kind of that tug of war you feel sometimes back and forth. It's known to result in nurses retreating from patient care situations and having decreased sensitivity. Bearing to suffer witness is another important concept to talk about. As nurses attempt to alleviate the suffering of patients and families, they also tend to look for the meaning of experiences and understand the why. Why did this happen? Why does this happen to those people? Why is this happening to me? Patient distress can be a primary reason that the environment feels stressful and the cause of job dissatisfaction. In the presence of suffering, nursing feels the need to find help. And when hope's lost, or when you can't find the answer to that why, it can extend suffering and create this feeling of futility. So burnout. It's a psychological syndrome resulting from prolonged response to chronic interpersonal stresses on the job. It leads to disengagement, dispersonalization, kind of checking out. Symptoms: apathy, self-protection, boredom, and depression. And the self-protection, that's not even really the right word, because you're really just trying to survive. It's survival mode. A higher level of burnout can lead to lower scores. Sure, it can lead to lower scores on your staff satisfied, but it really can lead to lower scores in safety and lower scores in patient quality care. It's not just that you're not happy with your job, but those things are bleeding over into the care you're providing to the patients. Nurses may feel that they're not able to recognize the human side of your job anymore, and that's really why you get into nursing, and so that's really disheartening. So I did put in here some methods of self-care because not all hope is lost, and there are things we can do to help. So I did put in here, just picked a few of those self-care things. Try thinking of 3 good things. Practice thinking of 3 good things. So you can range from big things to small things, and it can drastically improve your mood. It tries to cultivate positive recognition. And make it so you're reframing, you're kind of rethinking of your environment, and it creates a structured environment of purpose. Or if you don't like that one, try mindful self-compassion, meaning practice the compassion you give to others on yourself. That way you hold your feelings with a sense of connection and warmth instead of judging yourself or criticizing yourself. Greater self-compassion can lead to lower levels of anxiety and depression. The 3 things you can think about are mindful meditation, compassion meditation, or loving kindness meditation. And I thought that this was funny. It's one of those things where you just sometimes you're like, okay, this is fine, but what do you mean? I need to care about myself. I don't know how to do these things. I'm doing the best that I can. All those things sound fine, but how do I know that they're going to really help, or how do I know which one to pick? Well, if you didn't like my self ideas, which is okay, you can ask for help outside of here. As somebody that has personally talked to the people at EAP before, actually several times, I think they are very helpful. They're not somebody that is going to tell anybody that you talk to them, but they are somebody that is going to help you or help you get in touch with the right resources. Be it something stressful that happened at work, be it that you're struggling with a patient loss, which we all do and is normal, or be it just that you're not really sure what you're not really sure about. These are great people to talk to, and there's a lot of great programs with it. So this is from their website. They also have great tools. They have tools on here to manage your own stress. They have things about resetting, things about pausing, purposeful pauses. There's lots of great resources on their website. And again, it is an anonymous thing. You can call them, you can email them, you can do all of the things. But they are always there, and I think that they're great resources, and they're often underutilized. And this is a very, very hard patient topic, and a very thing that can weigh very heavily on you. So make sure that you're taking care of yourself and allowing yourself to process these feelings, so that way we can continue to provide this great care to patients. Hope you learned something. Hopefully we can do this again and we can talk about another topic that people suggested. All right, thanks.